We'll now move to questioning. I will begin and recognize myself for 5 minutes. Mr. Knuckles, beyond durable medical equipment, ill-intentioned providers are increasingly turning a profit by ordering expensive wound care supplies, also known as skin substitutes. Why are skin substitutes vulnerable to fraud and abuse?
That's a great question. I think the main reason that we've seen so much fraud in this is the large profit margins that providers have make when they utilize these products. Under the FDA clearance, the prices are not set by Medicare, and they have increased substantially. We in the ACO community have brought this issue up to CMS and to others for multiple times. We've asked for local coverage determinations to come in on this. The good news is that Secretary Oz has a decisive program that he implemented for starting January 1, and from the industry observers that I've talked to and other providers, I believe this problem is solved.
So you referenced that what happened January 1st was moving to skin substitutes to have a flat rate with the goal of reducing the fraud that had driven the high costs. Again, can I ask you for the record to reiterate, do you believe that this reform will reduce fraudulent or excessive billing for these services for skin substitutes?
It will absolutely reduce it, and I believe it will eliminate it.
Ms. Gay, are there fraud, waste, and abuse risks in state Medicaid programs when providers are allowed to self-attest to becoming enrolled?
I do believe. I will say most of my experience is not working directly with the states, but with managed care organizations and Medicare Advantage plans. But I do think that there needs to be additional oversight in our self-reporting across the board for eligibility, both for provider participation as well as member eligibility.
Do you think that there's increased risk of fraud in state Medicaid programs that provide services that are billed hourly, such as personal care services or adult daycare?
Absolutely.
New York's consumer-directed personal assistant program is under scrutiny due in large part to the increases in spending and the lack of provider oversight. In CDPAP, individuals hire their own caregivers, including immediate family members that are paid through a fiscal intermediary to provide assistance with daily living activities. In one case, a man signed up to be a personal caregiver for 10 relatives. To get away with this scheme, this man's brother posed as their mother, a recipient of Medicaid home care services herself and other welfare benefits. However, there's a little detail that was missed. She lives in Bangladesh, and she lived in Bangladesh for the entire time. This man was eventually caught and convicted for his crimes. Ms. Gay, are you aware of other state Medicaid programs or similar program designed to CDPAP for personal or home care services?
Yes.
What are the issues that you have identified with how this program and the category with that structuring has opened the door to so much overt fraud?
I think one of the things that we see that might be helpful, so oftentimes these personal care services are being rendered by somebody that doesn't have an MPI. An MPI is your national provider ID that you are supposed to use to bill. If I am setting up care for my mother, I don't have one of those IDs, and that billing goes under a TIN for an organization that I might be working with. So there's a discrepancy or a challenge, I guess, in how we look at that claims file data, and there's also disparate data sources. So if I am working through one MCO for one member and another MCO for another member, they can't see that I'm rendering services to multiple members, nor can they potentially see that it's me individually rendering those services at all. So there really is some data issues. I think our system was initially more designed for providers and practitioners that were billing services. And now that we're extending those services with good intention, we're creating other limitations in our ability to fight back.
Ms. Wooten, the HHS Office of Inspector General has recently begun a targeted review of fraud, waste, and abuse in Medicaid non-emergency medical transportation programs. In some cases, we have seen these non-emergent medical transportation providers bill for impossible amounts for the daily service, such as scores of unique trips that cover thousands of miles in a single day, which we know is unachievable. What aspects of these programs open the door for fraud?
Thank you. Because individuals are performing services where you're not in a hospital where there's administrators overseeing the program and knowing if the services occurred. Yet you will operate on a basis of trust. And we do see a great deal in the area of medical non-emergency transport. We see them billing for group rates or individual rates when groups are being transported. We see them billing for toll fees and other charges that were never incurred. We see ghost trips. Patients were never involved. And I think it is because they're a one-on-one type service or one on a small group that it's difficult to oversee.
Thank you. My time has expired. I now recognize the ranking member, Ms. Clark, for her 5 minutes of questioning.